This conference will now be recorded.
Or I can start.
Oh, I'm sorry. I said I'm still anonymizing some cases. I'll be
Yeah,
taking
I
a
can
couple minutes.
start. It's fine. There's plenty of time, so. All righty. Okay, so let's start with this first case. So this is a young person who presents with dyspnea on exertion. Presumably has some congenital anomalies, as you can see from the sagittal, has a kyphoscoliosis there, so kind of a hunchback type shape. So anyway, this is interesting because it's got two congenital things that may or may not be related. So you can see there's big right heart chambers here, suggesting pulmonary hypertension, or some kind of shunt maybe. There's bowing leftward of the interatrial septum, and the LV is kind of being squeezed. If we look, the aorta comes off the usual spot. There's the coronaries, the pulmonaries coming off the usual spot. But the first thing we'll notice is there's no left pulmonary artery coming off here. We just see some tiny thread-like vessels. And then we have a right aortic arch with an aberrant subclavian. And then there's this connection here between the pulmonary artery and the descending aorta. So we have a patent ductus arteriosus. And then if we look at the lung, we'll notice the left lung is small. It's hypovascular. And I'm pretty convinced it's missing some segments. The upper lobe seems to be missing at least a lingula or something, or it's just very small, but underdeveloped left lung. And then the right lung is a little heterogeneous, but other than that, it's morphologically okay. So we've got a patent ductus arteriosis. We have congenital or partial absence of the proximal interruption of the left pulmonary artery with bronchial artery supply, and a right aortic arch with aberrant subclavian. So I recall seeing the interrupted pulmonary artery contralateral to the arch more often than not, but I don't recall PDA being in the mix. So I don't know if it's just true, but the cause of his pulmonary hypertension, of course, is this shunt, and not having a good left lung isn't helping the matter, but kind of a neat congenital case. I'm David or Seth, or any of you guys aware of any relationship between the PDA and these pulmonary artery things? Because structurally it's different, right? You've got the embryonic aortic arches for the pulmonary artery, but the descending aorta is different structure.
How old is this patient?
24, I think.
Wow. Yeah, so he's got two causes for the bad pulmonary hypertension, right? With the proximal interruption plus the shunt.
Right. I wonder if there's some syndromic thing just given the kyphoscoliosis, or some kind of chromosomal thing. All right, this is kind of cool. So you may be doing this. This was the first one with these we've done here. So this patient had this lung nodule that looks like an adenocarcinoma. It's got a solid component. It's got ground glass. And you can see it's in a kind of a tough spot to get to for biopsy purposes, and it was going to come out. So they did a robotic guided bronchoscopy with the intent of trying to get a biopsy of it and getting a frozen section, and also marking it. And then rather than coming back a different day, go straight for surgery. So a single anesthesia event. So they got it, and actually on the frozen they got adenocarcinoma, but just in case they inject this dye that lights up in the OR, and you can see. So this is the piece right here, and that's where the lesion is. So the surgeon's able to skip the like a wedge for frozen and just go straight to either segmentectomy or lobectomy. And I kind of made this little collage here, but this is a screenshot. But it's kind of fun to see this, and I know it's been done at other places, but I think a neat little tool. And that way, if they don't get the tissue, the search for these, especially for these subsolid nodules, these ground glass ones, it makes it easier for the surgeons to find them, vats them out. For those you could do a frozen, see if you need to do anything. But it's a lot easier than trying to go percutaneously and put in. Some people use little fiducials and things like that. So that was fun.
Yeah, and Jeff, I will add, we were at UCSF, we were injecting that the indocyanine green
Right.
percutaneously too, in lieu of fiducials or wires or whatever. Yeah, it works great.
Yeah, so this is nice too. But the nice part is they can even get with the robot bronchoscopy, their yield's about 90%. So they can even get a positive frozen and just skip the OR time doesn't have to be wasted waiting for a frozen when you can just go in and do your lobectomy or doing more segmentectomies now. So here is a case. This is I can't remember how old it was. Let's see, 75-year-old, and presented with a mediastinal mass. I don't have any radiographs, unfortunately, and based on its location and solid component and the age, you'd favor thymoma. She's a little on the older side, but we do see them in this age. There's no calcium in it or anything else funny about it. And so this came out, and here's the specimen. You can see it's pretty well circumscribed. It had to take some lung next to it. Here you can see the pulmonary lobules adherent to it because it had grown into the lung. But you can see it's on this tissue here. It's got this really kind of dense white tissue there. So, and then this is just from the other side. So this is actually a solitary fibrous tumor arising from the mediastinum. And I've seen a few of these, and of course they can come anywhere in the body, but just a case showing that not every solid mass in older people in the prevascular space is a thymoma. But that's why we just take them out, because this would have to come out anyway. That's that case. And then this last case is kind of the most interesting, and I think David's going to love this one. If you've ever seen a PP33 ILO standard, I think this qualifies. So this is a young guy. He's 30, and he works in metal casting. So he does works where they manufacture metal parts, and they use cast with molds to make this. And he's been short of breath, and you can see on his radiograph, and I'll blow it up, and it may not show on your screens as well, but you can see the vessels are really hard to see. You can make them out, but they're all fuzzy. And if you look very carefully, there appears to be all these just tiny little dots everywhere. It's hard to see individual ones, but in aggregate, you kind of get the sense. And the heart border is fuzzy on both sides. Every little interface just isn't quite clear. There's maybe a few septal lines down here too, and they're very subtly nodular. So he had a CT scan, and this is what his lungs look like. I'm going to blow it up as well. And on first pass, if you're less experienced or just not attuned to it, you might say they don't look so bad. But as we get further down, they clearly are becoming more abnormal. And look along the fissures, you can see tiny, tiny little nodules. And as we get further and further down, you see a lot of septal lines as well. So clearly abnormal. I'll bring in the MIPS here, and you can just see how many nodules there are just everywhere. So like a miliary pattern, but definitely at the base is preferentially along the lymphatics with the septal lines and along the fissures, but it's almost too many to really sort out where they are. So in this metal casting, they use silica to line these molds to prevent the metal from sticking to the molds and stuff. And so he has had fairly intense silica exposure over a very short period of time. Now, I don't have tissue or anything, but I suspect this is probably more than just simple silicosis, and this is probably silicoproteinosis, given the septal lines, the rapid development. It doesn't have the classic upper lobe predominance, because I think he's inhaled so much over such a short period of time, it really hasn't had time to filter through the lymphatics. You'll notice his lymph nodes are normal. I mean, I guess the other possibility is sarcoid, but given his occupational exposures, and I'd favor this being occupational, but I think Seth showed a silicoproteinosis case, and I've seen one or two other ones. It's pretty rare. It requires a lot of exposure over a very short period of time, but that's my hunch of what's going on. If I get any, I don't know if they're going to end up biopsying him or what, or bronching him, but if they do, I'll let everybody know. But presumed silicoproteinosis, but definitely a rapidly progressive silicosis. And I haven't seen any of the manufactured stone cases myself, other than the ones you showed. But I wonder if those guys have similar distributions of disease because they're getting such a high concentration over a short period of time, rather than the traditional quarriers and miners that get more of the the upper lobe predominant pattern.
So the countertop fabrication people who are sawing and sanding that material called quartz, which is 95% silica. They look more like ordinary silicosis. It's just rapidly progressive. So it's an upper lung concentration that goes on to PMF rather rapidly. So you had one guy who's progressed over 3 years from an upper lung predominant small opacities to advanced PMF, required a lung transplant in his 30s. So it's an upper lung distribution. It's a very typical distribution. So I'm really perturbed by the basal predominance in your case, Jeff. I've not seen that from silica.
That's why I wonder if it's silica proteinuria, and a lot of what we're seeing is the protein buildup.
Yeah, or I wonder what else is going on in that factory. What all of his exposures are.
Yeah, I mean, there's metals of all sorts, but yeah, he may end up getting at least a bronchoscopy.
Yeah, you wonder if there's some component of a hard metal pneumoconiosis or something.
Yeah.
So anyway, it's a really nice example of a miliary pattern with a subtle perilymphatic. But I really like the radiograph because in the ILO classification, you don't see a lot of these P opacities very often in minors. So
Cool.
All right, who'd like to go next?
I can show some, but whatever fits.
All right.
Has a radiograph miraculously appeared in front of your eyeballs?
It has.
Okay, so this man has a couple of congenital conditions. Here he has, let's just scroll through his chest a little bit here. He has, this is an earlier radiograph from several years ago. He's fairly young. I think at this point he was probably 16 or so. So let me show you that he has some abnormalities. He's got a little bit of thymic tissue still at his age. And then we get down into his abdomen. Oh my goodness, he's got these lung nodules in his right base, a few of them clustered down there. Turns out he'd had an orchiectomy for a giant, embryonal cell carcinoma of his right testis. So he'd already had orchiectomy. We get down into the abdomen and we discover that he's got polycystic kidney disease. And so he has that. And then he's got some brain abnormalities here, which I hope to be able to show you here. Let's see. If we look at this lesion, he's got this lesion here, which was a giant cell astrocytoma, I'm told. Okay, so he's got brain findings that go along with tuberous sclerosis, and he has polycystic kidney disease. So this is the second case I've seen of this contiguous gene syndrome, where these two congenital diseases occur in the same person. I showed a case of this contiguous gene syndrome about 6 months ago, and this is the second case now, polycystic kidney disease along with tuberous sclerosis. And his lung lesions were suspected to be metastases. I've got an abdominal CT up here somewhere that I think I can show you. I think this goes farther down, that there was some there was a retroperitoneal metastasis. This lesion right here was thought to be metastasis from his kidney cancer. And then in the right lobe of his liver, this lesion, based on MR, is an angiomyolipoma of his liver. So he's got lots of manifestations of tuberous sclerosis. And in males, we don't expect to find the cystic abnormalities that we see in females, the LAM component of tuberous sclerosis. That's evidently doesn't occur in males. I've never seen it in men, but that could occur in a female with tuberous sclerosis. Okay, so contiguous gene syndrome, these two genes, the genes for polycystic kidney disease and for tuberous sclerosis are nearby, and it's possible to get a translocation or something like that that has both of those lesions, or a mutation that silences both of those normal gene products. So contiguous gene syndrome, two different conditions. This is not the only contiguous gene syndrome, but I think it's probably the most common. Okay. And this woman has, I think this is a different person, I hope, has a few small lung nodules scattered around. We see a few of them down here. And she had an upper lung lesion. Here's an upper lung nodule too. And so she's got small lung nodules, and then she has an abnormal PET scan here, shows a big splenic lesion. I don't know whether that's related to this condition, but then she's got these subcutaneous brightnesses lighting up, a few of those subcutaneous things. There's another one out here and stuff like that. And then she developed chest pain, and she has this CT scan showing this destructive lesion of her lower sternum here. And this shows up very nicely, I think, in sagittal, this big lesion here of her lower sternum with a lot of soft tissue component too. So, gosh, what do you think? Lung nodules, some subcutaneous nodules at some point, and then eventually this destructive sternal lesion. Any clues?
Could it be a malignant nerve sheath tumor from NF1 or something?
Okay, so here's our lung. These lung nodules persisted, and they sort of waxed and waned over several years. And, this all turns out
some fungal infection.
Okay, this is cocci. Very good, Travis.
Wow.
So this is coccidioidomycosis with lung lesions, subcutaneous nodules. I don't know about the spleen, whether that was the same thing. That eventually there's a cystic abnormality in the spleen with time, and then eventually a sternal osteomyelitis from cocci. So if I told you the person had TB and you saw lung nodules and you saw bone lesions, you'd say that's just fine for TB. But we've seen a number of cases of cocci do the same thing, really resemble TB. And at first, the presentation is thought to be TB because there are lung lesions and then bone infections as well. Okay, so that was cocci with eventually with an osteomyelitis. Okay. This person has cystic fibrosis, so we don't see very much cystic fibrosis coming to the clinic these days compared to what we saw before because of the Trikafta therapy, which manages to turn this into a much more benign condition with much slower progression and all. But this person does have a bronchial abnormality in both upper lungs, and then had a CT scan around early on, and we do see that there are a few mucus plugs in this person, or or at least maybe liquid mucus, and there is bronchiectasis, and I think there's a plug or two down here as well. Then the person developed a fierce eosinophilia, 57% eosinophils in the peripheral blood. That's a lot of eosinophils, and developed these ground glassy patches, which are consistent with an eosinophilic pneumonia. So lots of nice ground glassy stuff. Some of it's peripheral, it's upper lung predominant. And we don't have much in the way of mucus plugs, but this person had positive aspergillus precipitans. And this is a variety of allergic bronchopulmonary aspergillosis. The person has the allergic manifestations to aspergillus, even though we're not seeing the classic proximal mucus plugs and with high attenuation, all that sort of thing that would go along with their having aspergillus growing in them. So this person is undoubtedly colonized with aspergillus and is getting the allergic response to it, causing an eosinophilic pneumonia, but doesn't have the classic mucus plug. So it's all part of the same spectrum. It's an allergic response to the aspergillus. It's not infection that we're seeing here, so this is not invasive aspergillus. We're just not seeing the central airway, the central bronchiectasis with mucus plugging that's classic for it. So eosinophilic pneumonia I've seen before in people with allergic bronchopulmonary aspergillosis. So besides the mucus plugs, the central bronchiectasis, they can also get obstructive pneumonias behind the mucus plug. They can get infection from that, and they can also get eosinophilic pneumonia. So I've seen, I think, 2 other cases where there was a component of eosinophilic pneumonia. Okay, and then finally, I'd like to show you a lung nodule. This woman was a former smoker. She was at the right age, and so she went for lung cancer screening. And then lo and behold, she has this irregular, not quite spiculated, maybe a little spiculated, right upper lobe nodule, very suspicious for adenocarcinoma. And it lit up a little bit on PET scanning. So here we see it taking up some of the radio tracer, but not a whole lot. So kind of mildly positive. So this was resected, and it turns out to be an amyloidoma. And they found that there was a population of plasma cells that was restricted to kappa or lambda. I don't remember which. So an abnormal population of light chains, and then an amyloidoma. So it wasn't a lung cancer after all. It was kind of good news, but a solitary amyloidoma, who would have thunk? Okay, guys, thank you.
Thanks. Hey, David, is there any theory why people develop like a single amyloid thing outside of a systemic disease? Or is it the same story it was 20 years ago? We don't know.
Yeah, right. I don't know.
Okay.
I can go, Jeff,
All
if you
right.
want.
Yeah.
All right. Sorry. So this is not a conundrum, but an interesting example of this. So you can see this is a young patient in his 20s who's got exuberant soft tissue in his trachea in multiple different locations. And then this is a little weird. I don't know if that was an infarct or if that's a lesion, but you can see that there's all these soft tissue nodules, some of them cavitary or Cheerio-like. And then this is him in 2013. And some of the soft tissue, they probably lasered away, which obviously doesn't help for very long. And you can see how these cystic areas have blown up. Some of them are presumably infected with air fluid levels. And then here he is a couple of years later. And obviously the thing you're worried about is squame in these patients and with tracheobronchopathia. And he did develop multiple squames. You can see here, they actually tried to resect some of the papillomas, and he led to a kind of a robust reaction, has tracheal stenosis now. And then on top of that, he's got, where's my most recent one? One second. My most recent one really shows what happened to him, which is really unfortunate. So this thing kind of exploded, and he developed multiple squames throughout the lung. So in the right lower lobe, he had a squamous cell. He's got adenopathy. He had a left lower lobectomy because that lesion I showed before, that multiloculated cystic, was a squame. So this is just a pretty exuberant case of tracheobronchopapillomatosis over, I don't know, about 15 years. This case is kind of interesting because it has 2 unrelated interesting findings. So one is the patient came in for shortness of breath, and you could see probably one of the nicer, I mean, again, I call inflammatory HP, now it's called non-fibrotic. It's the inflammatory process associated with HP. There's no development of fibrotic tissue at this point, but you can see really beautiful upper lobe predominant central lobular nodules. Lower lobe has more pronounced mosaicism, presumably because, anyways, distribution disease. But what you can also notice is that there is a weird right lung. There's really no right upper lobe in terms of anatomically, and there's some weird venous structure, or so we called them and got a cardiac study, and did this at very low dose because I just did a flash from the belly up, and you can see that in fact and it's a weird kind of scimitar. So there is clearly a PAPVR that does drain into the IVC. We do have a hypoplastic right lung. But if you follow this guy here, he also does connect partially to the left atrium. So usually scimitar, there's no connection, but this one does have a partial connection to the left atrium. And you could actually follow this very weird, a lot of these weird vessels, you can follow them in all different directions. And the HP did get a little bit better after the treatment. You can see here nodules are less, but this is a variant of kind of a scimitar I've seen a couple times. There clearly is a hypoplastic right lung. There's no normal right upper lobe anatomy. It's even hard. I'm assuming there's no fissures on the right. I'm assuming this is right middle lobe, even though there's really no normal right middle lobe anatomy. It's just a completely hypoplastic right lung, and with this kind of scimitar variant in a patient with HP. So I thought that was kind of interesting. And they do talk about patients who do have residual communications to the left atrium. It's uncommon, but it does happen.
Also, also said that vein bent around a lot. It had a bizarre course, so it's kind of a wandering or meandering vein too.
Well, it's meandering in the sense that it's going all over the place, but it's primarily draining venous. It's one real vein on the right, and it's draining multiple venous areas. But yeah, it's meandering, but it's got a anatomic abnormality. One second. Hello? I'll be there in a second. Thanks, bud. All right, let me shoot through these. This one's kind of interesting. It's not that great. Let's see, which one is this? 2023. Oh, I downloaded the lungs. Yeah. Shoot. This is here. Endobronchial lesion that had been present. It's not a broncholith, although that was a possibility. It's hard to see. I downloaded the lung windows. I'm sorry, but there was some fat attenuation with this, and this was sucked out, and this was an endobronchial hamartoma. It's only the second endobronchial hamartoma I've seen. Not the best imaging on that, so I apologize. This is a case I just had the other day where the clinicians and some other people hadn't heard of it. I've seen a fair number of cases, but not a fair number, a couple. But this patient has a very narrow anterior to posterior diameter, but there's no pectus. Instead, there's kind of anterior migration, or not migration. The way the patient was born, the spine is more anterior than it should be. It's not actually anything doing with the sternum manubrium. Nonetheless, this patient has marked compression of their trachea, and we did dynamic expiratory, which it shows even worse compression. And this is related to something called and it's a form fruit of this, of straight back syndrome. So a lot of straight back syndromes do have a straighter back than this, what I'm showing here, but that anterior displacement of the spine with the compression of the trachea mediastinal structures between the manubrium and top portion of the sternum and the spine is pretty classic for this. And the clinicians had not heard of this before, and they were like, oh my God, because they looked it up and she looks exactly like this. Like her spine has no curve. It's the way she looks is very odd. So this was a case of really bad tracheal compression. And she also had mitral valve prolapse. This is associated with mitral valve prolapse, which she does have. Just not sure if people had known.
She also had a very high riding aortic arch, and it may just be because there's no room for it. It moves up.
Yeah, there's just no room for it in there. I mean, there's literally, 2 centimeters. But yeah, absolutely. So she's very symptomatic. So they're talking about removing the top portion of her manubrium and then doing a brachiocephalic bypass, which I think is pretty aggressive, but supposedly she is quite symptomatic. In this last case, did it download? Yeah, it did download. Okay, let's see if it'll work. So this is something that, I don't know, I was really impressed by. To me, this just looks like OP here, right? This is just a focal area, peribronchovascular consolidation. There's other areas, kind of whatever you want to call it. We all kind of know what kind of an OP can look like. And this was many years ago. And this is now 4 years later when I was reading a study. And lungs are clearly much worse, not in great shape, not UIP clearly, but some bizarre pattern of fibrosis. And I mean, I wouldn't even know what to call this, presumably OP with areas of fibrosis. Anyways, this patient was on, started nitrofurantoin in just a few months before the last CT. And this is before this, her studies were all normal. Supposedly she had normal chest x-rays. So supposedly this is a case of nitrofurantoin toxicity, which is, actually not, we have a bunch of cases here. These are always hard to pathologically prove. It's more of a temporal association, but that's what she's been called based on that. And we have a couple cases that are much more severe than this, of kind of OP turning into bad fibrosis in these older women taking macrobid for their, urinary tract infection prevention, which is kind of a nice example. But I have to run. I'm sorry.
Thanks,
A meeting to go to. All right. Take care.
Yeah. Thanks,
Thank
bye.
you.
All right, Travis, you ready?
Sure.
All right.
Let me just know when you can see the screen there. Yeah, I was hoping that Seth could stay on for this first one. You guys see a CT?
Yeah.
Yes.
This is a trauma patient, and it was a motor vehicle, I don't want to say crash or accident, because she apparently jumped out of a car that was moving at 20 to 30 miles an hour. And this was her trauma CT. She had a pneumothorax, had a chest tube placed, and you can see that her left lung, there's a considerable amount of consolidation, ground glass in it. Some of this is atelectasis, and some of this looks more like laceration and contusion, and then a little bit of hemothorax as well. The interesting part about this is her pericardial effusion, and it really. Let me see. I'm gonna thicken these up a little. These are like 0.6 millimeter. Because at least when you first look at it, it doesn't look that high attenuation like you would expect for hemopericardium. Let's see what the attenuation actually is. It's like a mean of 40. So certainly is just relative to that hemothorax, it looks a little less. So, this was not detected at the time. This is actually an older case that I just came across, but it's really interesting. So, looking for a source of bleeding into the pericardium, this is just air from the injection there. You don't really see anything. The aorta looks fine. The pulmonary arteries look fine. And in fact, the pulmonary veins look fine, at least out in this lung where you have this focal abnormality. So the surgeons went in. This was all hemopericardium. They drained it, and then they found an injury to the left inferior pulmonary vein. And I think it is the only thing that you can really see is this. And it's not even occluding the vein. It's just that there was some sort of laceration to that left inferior pulmonary vein. So I mean, I didn't see the imaging and, and whatever happened to Princess Diana, but apparently that she had a pulmonary vein injury as well. But obviously you can see the only thing you really see is right in here. It's just a little bit of irregularity to that left inferior pulmonary vein. Now, I don't know, I can't remember if anybody's shown a pulmonary vein injury before or not. Jeff, had you shown one?
Not that I recall. I don't remember seeing one.
Okay.
They're
Yeah,
pretty
I mean,
rare.
yeah.
because they're usually
And for this
fatal
patient
or
to survive, I mean, yeah, this patient's fine. It's crazy too that you know, she bounced pretty good, I guess, for lack of a better term, because there is no rib fracture on that side, nothing. So I don't know, crazy.
yeah.
So everything
All
cleared
right.
up, Travis, on subsequent imaging. Everything was gone.
Well, once they went to the OR and repaired the pulmonary vein, yeah,
So the lung cleared up and everything like that.
yep. And I admittedly don't have any of the follow-up imaging here, but yeah, she spent a couple weeks in the hospital, discharged fine, and things were at least improving.
So what do you think they did to the vein? How would they repair something like that?
The cardiac surgeon, they did a full sternotomy, went in and did some sort of patch to the vein. I'll
Okay,
I'll have to pull up the operative note again and look.
okay, cool.
But they weren't expecting to see that because it was actually one of the thoracic surgeons that was the first person in the OR, and when they did a pericardiocentesis and saw that it was blood, and that's when they got the cardiac surgeon involved and opened her up and then realized there was an injury as she kept bleeding. All right, let's see which one this. Okay, this is an interesting one. I'm curious what you guys think. This is more of just a curiosity than anything else. So this is a patient who came in with an acute type B intramural hematoma. It's not very impressive, but they had back pain, hypertension. There's a little bit of a crescent here. And I do have a non-con, and I'll show you. That's not really why I'm showing this, though. I saw a follow-up on this patient. You can see they've had a prior right upper lobectomy, and looks like a talc pleurodesis on the right. And this is the interesting thing right here. This little gumdrop shaped thing just anterior to the aorta at the diaphragmatic hiatus. Because when you look at it, you think maybe this is enhancing. I've already pointed out, I think, one of the pertinent findings, which is the talc pleurodesis on that side. Because I was looking at this and someone had asked what it was, and it's like, well, I think that's the answer on the non-con. So I think it must be talc that drained into the cisterna chyli here. I'm curious. I don't think I've ever noticed this. Certainly, when we've seen stuff accumulate in here when patients undergo lymphangiograms, but usually that's from the groin going up. I don't know if I've ever seen things retrograde from the pleura, get into the lymphatics and go here. Have you guys?
No.
Or could it just be a lymph node too, obviously? And here's the
Or is
intramural hematoma.
any
But
any chance there's a pleural recess tucked way in there and we're just catching a little blob of it? Sometimes the pleura
maybe,
folds in deep.
I mean,
Probably not.
yeah, I mean,
It's
I
too.
guess, you know, that's a reason. I don't know. That's a reasonable thought. I mean, it doesn't, again, it's an academic point. It looks like it's
Right,
more
right.
just tucked in the fat with the hiatus here, but
Can you follow the thoracic
clearly
duct
not
out
to
of it?
be. What's that?
Can you follow the thoracic duct out of it?
Oh, that's a good question too. And no, I couldn't. That was the other frustrating part of this. Yeah, because normally or oftentimes you can see the thoracic duct, as we know, but I don't know if this. I was wondering if this is thoracic duct right here, in which case it's too far posterior. I don't know. It's just, yeah, I hadn't
I don't even
thought
see the
about it being a.
azygous vein.
And Travis, we don't think this person ever had a lymphangiogram.
That's it there, that little dinky thing.
No, David, to that question, I don't know the answer, but I don't think so. They were just, we have very sparse records. They were transferred, I think, from the VA with this intramural hematoma. So, I mean, the point is, it's not a hypervascular thing, clearly with the non-con, but just
Right.
it's similar attenuation to the talc. So I think it's talc, just the question of where it is.
Uh-huh.
Because David, there's nothing lipidol or anything else in any of the other lymphatic areas. And of course, he's had a AAA repair, it looks like, as well. And this is contrast from the prior CT. But yeah, I don't know. I just thought this was curious. I mean, it's right in the region where you see the cisterna chyli. So I don't know. right, and then this one, kind of an interesting radiograph here. So this is another trauma. This is I was reading a follow-up. This was not this patient's current admission, but a prior admission. And you can see the interesting finding here. In addition to the chest tubes, these are little needle decompression that they did, I think, in the field. And then, of course, air surrounding that right there. And she does have a right-sided implant as well. So, just fairly impressive CT here with all of the air that's subcutaneous. And then also, I don't know how necessarily the air got into the and expanded the breast capsule, but I'm assuming this is basically like what an intracapsular rupture is for a breast implant. But, there's just a ton of air really confined to that. Obviously, it extends out elsewhere. I don't know. I don't have a better explanation than this is just around the fibrous capsule that develops when you have an implant.
Travis,
Do you guys have more?
Let's follow that chest tube, which is just going into the chest wall. I'll bet you it's that might be the source of the error.
Well, I think it's actually those needle decompression tubes I pointed out right here. I think those are the source. Yeah. So they're going through that. But the question, I'm confused. I just wonder how this happens because they didn't collapse. I don't think it ruptured the actual implant itself. I think it's just air that got into the fibrous capsule around it because it's saline. It would just deflate.
Mm-hmm.
I don't know. I was hoping you guys had a more eloquent explanation for that, but
I like your explanation.
And I don't know. Maybe there was already air.
There's an intercostal tear, and and then their little decompression things just made a fistula, and it probably is an easy plane to dissect.
Yeah, and then this, of course, is follow-up, and all the air is gone. So yeah, I guess maybe it was the trauma that caused air to dissect into there, and then that gave them the space to put those decompression tubes through it. Because if the fibrous capsule is right next to the implant, then in theory you would have just punctured the implant when you put these in, right?
Right.
If there was no air already there. I don't know.
So did the person must have arrived with pneumothorax, or were the drains placed presumably for pneumothorax and not for effusion?
Yeah.
Right?
Yeah.
So there was a pneumothorax, meaning, there could have been a disruption of the chest wall already.
Right, that's what I'm thinking.
Yeah.
Yeah, because you can see that there's at least one. Well, she's got a lot of motion there, but it looked like. Well, that's weird. It looks like a fracture with just some associated motion with it. So, and there's another. Yeah, there's the second rib fracture there, and then that third was broken as well. So, yeah, and these look like little decompression needle tubes that they would have put in the field, presumably.
Mm-hmm.
So I think the disruption must have already been there, and then just probably poking it through there just increased the amount of air that surrounded the implant within the capsule. But I don't know, just this was quite an impressive radiograph.
Yeah. Pneumomastia.
Yeah. Okay, so two of these back to back. Within, we have a ton of left ventricular assist device placed here, as I'm sure you guys do too. You see some. We see a boatload of them. And I will, I've said this before, and I think, when people are unaware, they just see anything and call it thrombus. This is a HeartMate 3. We saw the same thing with the HeartMate 2. But you can see there is eccentric low attenuation along the outflow cannula, and it's really confined to the bend relief portion, so that you can see the actual structure of the outflow cannula changes right here, where you have these are Gore-Tex rings, and then you have the rest of the outflow cannula. And I still have personally never seen a case proven and shown to me that was proven to be thrombus in the LV outflow cannula. And I've seen probably 25 or 30 cases now confirmed to be what this is, which is just biodebris that accumulates in the outflow cannula. So this patient had low flow alarms, and you can see it has that kind of eccentric look to it. And this is done on our photon counting scanner, so you're seeing a little bit of a different reconstruction algorithm, just artifact here. But it gets that extrinsic compression where you can see it's really deforming that tube and pushing it inward, when you often get this stellate or this kind of, comma-shaped or elliptical shaped appearance to it. But this patient did go to the OR, and so the bend relief is the tube within a tube here as the outflow cannula bends. So when they go into this first layer, there's contents of this biodebris, which is just proteinaceous material and whatever that's under pressure. And so this stuff will drain out, and then their low flow alarms instantly improve, as it did in this case. So again, not thrombus. This is just stuff accumulating, outside the outflow cannula within the bend relief.
So when they remove that stuff, are they able to seal up that outer tube again?
Yeah. And that's a good question. I don't know how they do it. I have they really just talk about they incise the bend relief, they evacuate the, and they don't really talk about how they seal it back up. But that was one, and then that was one I saw this past weekend. And then one of my colleagues was like, oh, well, this reminds them of one that they saw. This was back in the fall. And same deal, outflow, alarms. And this one's interesting too, because it's, same type. And you have the bend relief here, and you can see those Gore-Tex rings here. And within the bend relief, it looks very similar. It's got that kind of wave-like appearance on the axial, and I can reconstruct it. But in this one, the narrowing actually extended further into the outflow cannula, and there's a little bit of artifact right in here, but you can see it's still that eccentric. And so, our rule of it usually never extending beyond here was broken in this case, but this was another one. This was all biodebris. And when they went in, same thing, contents under pressure that relieved and improved the flow alarms. So, like I said, normally in most cases, it's confined to this portion that has the more radiopaque rings, but in this case, it, for whatever reason, was tracking further along. And yeah, I don't know, David, I'll have to ask and see, what they do to actually seal up this bend relief. But you can see it's the same, or if they even do, I don't know, but it's the same, that eccentric narrowing of the lumen. And this one was considerably more narrow right there. So but yeah, again, if anybody has
how does this biomaterial get into that space? I don't
know.
Yeah.
Yeah, I mean, there are lots of case reports and case series of this published and I don't know. Mm-hmm. I think it's like Jeff's question about why do patients get a single amyloidoma? I don't know.
Maybe the same reason.
That sounds good to me.
Keep it simple.
Yeah, and then I'll this is one I'll follow. I'll finish on, and this was an outpatient non-contrast, and I don't think it was a lung cancer screener. I think it was just an outpatient, and one of my residents saw this on call and was just looking at this in the evening, and after reading this, we would like to offer her a job on the spot, because she correctly recognized this and thought maybe this was a pulmonary infarct, unprompted, and called the physician. They brought the patient into the ER that later that same night or the next morning, and sure enough, you can see fairly extensive pulmonary emboli on that side. And yeah, I think by this point you've got some lysis of clot as the subsegmental vessel going to this area is now opacified, but maybe some of it's not right there. But again, great look for an infarct with that kind of the reversed halo with the consolidation and the central lucency, and then, you know, a little bit of consolidation next to it. But, you know, it was, again, recognizing infarcts on non-cons, I think, can be helpful.
So, you know, it's a bird's nest, isn't it?
Yeah. Oh, yeah.
I'm just wondering whether
Hummingbird.
the Mucor bird's nest is the same as this kind of bird's nest, which means bird's nest means infarction.
Yeah, I think it is. I mean, right, when we see those cases of mucor where you have macroscopic, like true angioinvasion, and you compromise the blood supply to that, you know, segment. It's interesting in the cases of mucor, you know, where you have an entire lobe even affected, or at least a big segment. I mean, it tends to be bigger areas of infarction.
Right.
Like Jeff was saying, then this is the hummingbird nest, you know, much smaller than, you know, some hawk's nest.
Yeah. And,
So,
you know, and the venous infarcts look similar too. So the underlying mechanism seems to be infarction rather. It's not determined. It doesn't depend on whether the artery is invaded or whether the vein
yeah.
is. You obstruct either one, you get infarction, and then you get this sort of central bird's nest thingy.
Yeah, and I
Another
guess
clue on this.
Go ahead, Jeff.
I was gonna say another clue on the scan is that it's subtle, but there's a tiny pleural effusion, which you
Yep.
wouldn't get without atelectasis.
Yep.
And the
Right.
other thing is that the tissue is not enhancing, so that lung consolidation is not enhancing because it's avascular.
Yeah. And yeah, and as of course, like we're saying, it's, you know, it's not infarct in the necrosis sense in most cases, just hemorrhage, you know, in these, since it should heal. So, all right. Jeff, I think that's all I had for today.
Yeah. Great. Well, thanks for all the good cases. All
Thanks,
righty. Well,
Ray.
that's it. We'll call it a day. Talk to you all later.
Thanks, everybody.
Thank you.
Bye.
See you next
Bye-bye.
week.